è veramente un onore per me chiamare Maria Jessup a parlare del secondo tema, che è particolarmente difficile. Sono tutti temi difficili questi di questa sessione. Ci siamo impegnati e chiedo alla professoressa Jessup, che è nostra ospite graditissima sempre, quest'anno di trattare la fisiopatologia della acute decompensated heart failure. Quanti compiti ci sono in questo crimine, e credo che Marielle ci darà un insight davvero inatteso. Prego, Marielle.
Thank you, dear colleagues, ladies and gentlemen. It's my pleasure to be here with you to address the partners in the crime. And the crime that I'm addressing is acute decompensated heart failure. As you've heard from Dr. De Simone, there are both systolic HFrEF and diastolic HFpEF heart failure that can become decompensated. And it may be from a patient who has had prior episodes of heart failure, or it may be new onset heart failure. So I'm going to touch on a few causes of why people may decompensate and develop the syndrome that we know of as acute decompensated heart failure. And I would propose an organization that touches on just a few things, including myocardial remodeling, vascular remodeling, vascular inflammation, the component of renal function or dysfunction. There's a lot of discussion around obesity, even things like air pollution and miscellaneous, including noncompliance, and our inability to really know what's the right thing to tell our patients about lifestyle. So in this paper that looked at HFpEF, and it was in the TopCat trial, I think there was some very important findings here. And that is that as we look at patients with HFpEF, we have to realize we can't make assumptions about the underlying cardiac structure. And we heard that from Dr. De Simone also. So in this TopCat trial, they categorized the patients that looked at the differences in left ventricular geometry. A percentage had normal, some had concentric remodeling, some had concentric hypertrophy, and others had eccentric hypertrophy. It may be that depending on the way the heart looks, there may be multiple different reasons why there's decompensation. Likewise, left atrial size is highly disparate between those that have normal left atrial size all the way to those that have severely enlarged left atrium. Again, it may be that decompensation occurs differently in these different left atrial sizes, as the left atrium can serve as an area of capacitance, but may likewise prove to be a stimulus for atrial fibrillation. And finally, just categorizing the diastolic dysfunction can be all the way to normal versus very severe. So my prejudice is that as we look at the HFpEF patients that come in with acute decompensated heart failure, it's not surprising that one treatment may not fit all. A second issue is to talk about vascular remodeling. In this depiction, it outlines the composition of vessels across the circulatory system. Let's see if I can point, I guess here. Yes, oops. Tricky. So on the left-hand side, you see the aorta, and if you look at the amount of elastic tissue as we get from the large aorta all the way down to the capillaries, the relatively high elastic tissue in large conduit arteries favors the ability to absorb and release energy. So in this cartoon, what you see is that during systole, arterial blood flow through the capillaries, as a result of the arteries are normally compliant, and they serve to further sending the blood throughout the system. And during ventricular diastole, as the left heart is filling, the elastic recoil of the aorta sends blood along. And this elastic component is very important. So in the compliant arteries, the capacitance to send blood flow forward, this stress strain curve, the line underneath this stress strain relationship shows a much higher amount of blood than in the very tricky. Than in the brittle vascular space. So that in the effect of reduced conduit vessel elasticity is shown in this slide. On the left, you have normal systole, but the conduit artery, in this case the aorta, does not have the capacitance to hold the same amount of blood volume. Furthermore, during diastole, that blood flow is not passed on further. So I would submit that in acute decompensated heart failure, this vascular stiffness, which may be augmented by either increasing salt and fluid retention or more commonly hypertension, acute hypertensive crisis, can impact on this vascular compliance issue. This relationship of arterial stiffness and wave reflections was shown in this study that was published quite some time ago, looking at 336 patients hospitalized with acute decompensated heart failure. They all had ejection fractions over 50%. They underwent invasive and non-invasive assessments of diastolic function, as well as assessment of arterial stiffness and wave reflection. The arterial pulse wave velocity, which is a measurement of vascular stiffness, was the most powerful predictor of increased end diastolic pressure. And in multivariate analysis, female gender and higher pulse wave velocity were independently associated with symptoms. Again, showing that in these patients with acute decompensated heart failure, the measurement of end diastolic pressure was most correlated with vascular stiffness. And this is shown as the symptoms increased. As the symptoms increased from New York Heart Association class 1 to 3, the left ventricular end diastolic pressure goes up. The E septal is a measurement of pulse wave activity, and this is likewise shown here as well. So this pulse wave activity, this arterial stiffness, is an important pathophysiologic component. We don't understand very well what would cause an increase in this arterial stiffness, but it's certainly why we see heart failure in elderly patients. Similarly, every patient that has diastolic dysfunction may in fact not have heart failure, and we heard that previously. This paper looks at controls, patients with left ventricular hypertrophy, and patients with HFpEF. They have the clinical syndrome. And as you can see, even as everything else is very similar, the E to A ratio, the left ventricular end diastolic volume, the only thing that really turns out to be different is this E to E prime ratio, which is a way that we measure diastolic functional grade. So in addition to the vascular wall stiffness, there is some myocardial stiffness that accounts for acute decompensated heart failure. You saw this paper earlier. This is a beautiful summary that was recently published in JACC that looks at the paradigm for HFpEF development. They describe a systemic pro-inflammatory state induced by all the comorbidities that we know very much that causes myocardial structural and functional alterations. The comorbidities, which include overweight and obesity, diabetes, chronic obstructive pulmonary disease, and salt-sensitive hypertension induce a pro-inflammatory state. This causes, in its turn, microvascular endothelial inflammation. This coronary microvascular endothelial inflammation reduces nitric oxide bioavailability, cyclic guanosine monophosphate content, and protein kinase G activity in the adjacent cardiomyocytes. The low PKG activity favors hypertrophy development and increases resting tension. And this results in changes in the titin, which is part of the contractile elements in the myocytes, and develops both stiff cardiomyocytes and interstitial fibrosis. This is shown in this schematic which you just saw, again pointing to the reactive oxygen species in the endothelium of the vascular that subsequently causes myocardial dysfunction. This is different than what we see in HFrEF, where the reactive oxygen species develops within the myocyte themselves. But what's important and what we don't understand, especially in acute decompensated heart failure, is under advanced HFrEF, which can look a lot like advanced HFpEF, where there is both oxidative species within the myocytes as well as oxidative species within the vascular endothelium. So although this paper says it's primarily with HFrEF, I would submit in the patient with severe HFpEF, the same can be said. I'll switch now, after the discussion of remodeling, to the impact of renal dysfunction. This paper comes from the study, the PROTECT study, where they looked at serial measurements of blood urea, nitrogen, and creatinine to describe trajectories of renal function. What they saw is that the 100-day mortality as a function of baseline BUN could be described so that there was a big difference in mortality at a baseline BUN of 40 at 80 compared to 40, and the same as a change in creatinine. And they concluded that patients with acute heart failure and renal dysfunction demonstrate variable rise and fall in renal indices during and immediately after hospitalization. The risk of morbidity and mortality can be predicted based on the baseline renal function and creatinine trajectory. I would submit that not only is there renal dysfunction important in the acute decompensated heart failure, but it determines how poorly we can treat them. So this study, the Rose Acute Heart Failure Study, showed absolutely no benefit of dopamine, virtually no benefit in aceretide, and as a further demonstration, this study looked at the effectiveness of aceretide and predictors of urine output. They saw that the more furosemide that was given, the higher the the urine volume. But if you looked at whether they had low BUN or high BUN, low creatinine, high creatinine, there was really no impact. So that renal dysfunction predicts what's going to happen. In the case of drug therapy, it doesn't seem to really determine, and certainly in a drug that doesn't have much value. In addition, there are causes of diuretic resistance that is a long list of diuretic resistance that may cause acute decompensated heart failure, but I would point out to the patient noncompliance. If patient doesn't take their medicines, they're going to decompensate, and there are certainly drugs that can cause decompensation, including NSAIDs and other drugs. There is, in addition, the patient noncompliance of taking too much salt. I want to finish by talking about body mass index. This was a very big study looking at 6,000 patients with acute decompensated heart failure from 12 cohorts. And what they showed is what we suspected, that the thinner the patient, the higher their 30-day and 1-year all-cause mortality. So the obesity paradox was confirmed. And this was true in all subgroups, so that BMI related to all-cause mortality seems to hold in many countries and in all age groups. So it's really specific to all groups. Finally, there's other reasons that precipitate acute decompensated heart failure. I already said non-adherence with medication regimen, acute myocardial ischemia, uncorrected high blood pressure, atrial fibrillation. I don't want to hear that horrible sound, so I'm talking really fast now. I'm going to finish by a very provocative idea that there can be air pollution. And certainly in some countries, they're already beginning to see acute decompensated heart failure as a result of air pollution, and I'll skip through that. That just looks at a number of different papers looking at an increase in mortality risk with higher incidence of particulate. And this shows not only cardiovascular toxicity is up with short-term and long-term, yes, got it, but also heart failure and systemic inflammation. So we constantly are looking inward for reasons for decompensated heart failure, but we may have to prepare to look outside as well. I'll skip this because I'm over. So I'll finish by saying I think there are many crime partners. We'll have a hard time arresting just one. And they include myocardial remodeling, vascular inflammation, renal dysfunction, obesity, air pollution, and noncompliance with regimen. Thank you very much.